So this is a little bit more pre-learning. I hope you find it useful. Rather than have a face-to-face session on imaging of cervical trauma, this is quite a useful little refresher for you on current concepts and thinking. So I'd like to declare that I'm really interested in trauma and spine trauma in particular, but I have no conflicts of interest or disclosures. In the United Kingdom, we tend to use the term declarations of interest, and I have no risk of bias in this. So just a little bit of stuff around knowledge. We have head, hand and heart, and this is the knowledge you can get from books. Hands are the skills that you might have, that's either soft skills or motor skills, and then heart is the judgment and wisdom that you might bring to something. So not all cervical trauma requires imaging, and the Canadian rules are really helpful for assisting you in making that judgment. Obviously we do require imaging if there's significant trauma and a significant history, but the Canadian rules actually help you enormously in reducing unnecessary x-rays in patients who the x-rays are unlikely to have any yield, and in fact specialist imaging is unlikely to have any yield. So in most trauma units, CT or MRI would be the imaging of choice, and simple cervical x-rays may be much more appropriate in a low-cost environment such as that of Ethiopia. Essentially, if the patient's older than 65 years old, there's a dangerous mechanism, and there's any neurological symptoms or signs, you're going to image. You may not need to image if the patient has been ambulatory at any time, if there was a delayed onset of neck pain, if there's no point tenderness on pressing specifically in the midline of the cervical spine, and if it's a fairly low energy event. Also, if the patient's reasonably comfortable and can move their neck comfortably, then you know that they don't really need any neurology. I'd commend you to have a look at the specific articles. Most of us consider that the imaging of choice in cervical trauma is actually a CT scan. It gives you the most information in the shortest time frame, and specifically it's extremely helpful and probably your first imaging modality if it's available to you. If it's not available to you, you're going to have to resort to clinical skills and plain radiography. So your imaging protocol will be plain radiography for first level minor trauma, certainly a CT scan, and if you're scanning the head, please scan the cervical spine, and this would be first level for major trauma or polytrauma. The MRI scan really is for soft tissue assessment and perhaps assessing any cord injury. So if there's neurology present, you're going to be far more likely to carry out an MRI scan. And also if you're uncertain about the date of an injury, an MRI scan will be really helpful in that porotic fractures or determining whether for example, a dontoid peg fracture is new or old is often helped with an MRI scan. Plain X-ray, AP, you should certainly be able to see at least C3 to T1, but obviously you want to see the occiput too on lateral views, and a transoral view is useful for checking symmetry. More complex x-rays, you really don't want to be doing these unless you don't have access to a CT scan. You can waste a lot of time trying to get swimmer's views, oblique views to check the foramina, and dynamic views. With dynamic views, flexion extension, you need to decide whether the patient needs to be supervised or unsupervised. My simple rule of thumb is that if they have neurology, they probably need to be supervised. If there is no neurology, you take them through a passive range of extreme of extension, extreme of flexion. If that doesn't precipitate neurology, they're probably safe to be unsupervised. Here we have the standard survey, a lateral good quality X-ray of the cervical spine, an AP and a transoral view showing the peg and the lateral masses. When it comes to specifics of what you're looking at, there's the anterior profile, there's the line that's made of the posterior vertebral bodies, and then there's the spinolaminar line, which is basically the lamina just under the spinous process. You're looking for the smoothness of that alignment, and then on the AP X-ray you're also looking to see whether all the spinous processes are in alignment, and if there is a slight step it might suggest a unilateral facet dislocation. The transoral view is useful for seeing the upper cervical spine, in particular C0 to some extent, but more specifically C1, C2 and possibly C3. You're looking for symmetry, you're looking for subluxation of the facet joints or any overhanging of the lateral masses. Specialist cervical x-rays such as the swimmer view can be very time consuming. If you've got an ill patient, you really don't want them getting cold in an x-ray department, having ever more x-rays. So if you've got access to CT scanning, that's the ideal modality. Swimmer views can be difficult to interpret, but they can sometimes show you the C7, T1 and T2 areas. The open mouth peg view gives you a good clear view of the peg. It will also show you the C1, C2 articulation, and what you want to look for is whether the lateral masses have been displaced or widened and there's any overhanging of the lateral masses of C1 on C2 or any asymmetry to suggest atlantoaxial subluxation, particularly in children. In any X-ray, you want to look at the age of the patient, date of the X-ray, you look at the bony alignment around every bony outline, bone texture, and then you look at the soft tissues. And specifically on cervical spine X-rays, you're looking at the prevertebral soft tissue for hematomas. There's various things are stated about the normal retropharyngeal space and the normal amount of soft tissue in front of the vertebral bodies. It's generally held that 6 millimeters at C2 and 20 millimeters at C6. Outside these parameters, you should consider whether there's been a fracture or similar producing soft tissue edema. Some of the soft tissue changes are more subtle than others. You can see anterior to the C1, C2 axis, just a little swelling there. As that's the distance that actually impacts upon the available spinal cord dimensions. You can see on the left side where there's a unifacetal problem, and that's only really picked up by looking at that gentle curve made by the posterior cortex of the vertebral bodies. You should also look at the interspinous spaces. If there's a widening of the interspinous space and a step, it does suggest a unilateral facet problem, subluxation or dislocation even, as is clearly seen here. Special cervical x-rays, such as the oblique views, look specifically at the foramen, also sometimes called pillar views. Often radiographers will take a number of shots to get the right x-ray, and so it depends also on the skill level of your radiographers. They can be useful for picking up injuries to the lateral masses, injuries to the facet joints, and facetal dislocations. A real measure of stability is given by flexion extension x-rays. You can get a measure of the degree of extension by looking at the occiput to posterior arch of C1, and also a degree of the flexion by looking at the distance between the mandible and the spine. To me, if somebody has any neurological symptoms or signs, you should be very cautious about doing flexion extension x-rays without other imaging modality first. Probably we use it most commonly in the assessment of fracture healing and stability at maybe 6 weeks or 3 months post-injury. You really want to assess the quality of the lateral x-ray. You need to be able to see C1 down to T1, ideally to the inferior body of T1, checking the horizontal nature of the jaw, that all the vertebral bodies have a good square shape, that the disc spaces are reasonably preserved and symmetrical, and also look at the soft tissues and the spinous processes. In trauma, CT cervical spine is really your first level investigation. If somebody's had a head injury and you're going to CT scan them anyway, we've spent many years persuading our radiology colleagues to scan the cervical spine at the same time, and certainly it would be my imaging of choice for spinal trauma, that is CT scan. I'm not sure how available it is to you. It's certainly a fast imaging procedure. You can acquire the images in a very short time period, and if they're in the CT scan for other injuries, it makes an awful lot of sense to get as much information as you can at the one setting. These are some of the indications for CT scanning of the cervical spine in trauma. They also apply to the thoracic spine and lumbar spine. There are a number of measurements that you can do, and various ratios, power lines and X lines. The distances may vary from population to population and from age, but essentially what you're looking for is separation of the bony structures that suggests a ligamentous injury. Condylar disruption, particularly C0, C1 injuries, occur with high velocity. They're easily missed. They're most readily seen on CT imaging, and you need to look both at the smoothness of the joint and any separation or subluxation of the joint. For some spinal injuries, we'll apply traction. You need to be aware of the danger and risk of distracting a soft tissue injury, and certainly I would strongly recommend, after the application of halo traction, imaging is undertaken to make sure that you're not over distracting, and there's various guidelines about the weights to apply. These are some images of the arch fractures that can occur. Obviously, when you have an arch fracture, you need to consider whether the alar transverse ligament is intact or not, and there may be a small avulsion fragment to suggest avulsion of the transverse ligament, which again will guide your judgment in terms of the stability of the C1, C2 axis. Odontoid peg fractures are common, particularly if you have somebody who's had a fall and they have a abrasion of their face. Particularly in elderly patients, consider whether there may be odontoid fractures present. Odontoid fractures are classified according to the Anderson and D'Alonzo classification. Type 1 are relatively rare. They're often mistaken or confused with os odontodium. Type 2 fractures generate a lot of excitement because of the instance of non-union, but non-union in the elderly may be a fairly benign disorder. Type 3 fractures, because they have a large cancellous bone surface, will invariably heal with not too much in the way of immobilization or intervention. Injuries of the upper cervical spine are often associated with retropharyngeal edema, so always look at the soft tissue quite carefully. Here there's a C6, C7 fracture dislocation. One would anticipate that there might be associated neurology depending on the speed at which this occurred, and often multiple imaging modalities are required. With bifacetal dislocations, the earlier that can be reduced, the better for the vascularity and hemodynamics of the spinal cord. Initially there may be no neurological deficit, but as a consequence of venous engorgement, particularly with low velocity bifacetal dislocations, neurology can develop. And so in these cases it's really important to move as rapidly as possible to a either closed or open reduction depending on your available resources. If on CT imaging, on the axial image, you see any fracture that involves the vertebral artery foramen, consider whether you need to have specialist imaging. A vertebral artery injury can be catastrophic. Late thrombosis and embolic phenomena can occur, and even in the presence of trauma, you need to consider whether anticoagulation might be required. Specialist imaging, if you are going to be carrying out any operative reduction, guides you around the variations in the course of the vertebral artery that can occur. The anatomy of the vertebral arteries can be very variable, and loops within it can occur. We'll discuss this in some of our cadaveric work on the anterior approaches, but you need to be aware of the enormous number of anatomic variations. There are various ways of assessing the patency of vertebral arteries: angiography, MR angiography, or even CT angiography, and it depends on the resource available to you. Injury of the vertebral artery, although uncommon, can occur, and the risk is progressive neurological or permanent neurological problems. Generally speaking, if you can identify that there's an intimal stenosis or something of that nature, anticoagulation will reduce the risk of thromboembolic phenomena. Generally speaking, for emergency trauma, we don't go straight to MRI scan, but MRI scan may be helpful in a more detailed evaluation. Certainly patients with a neurological deficit, but normal imaging of CT and plain X-ray, we should consider MR. Very often MRs can be undertaken with halo vests or collars, and they give a lot of information regarding the soft tissues and in particular the spinal cord. MRI scans are really helpful and useful for assessing ligamentous injuries, particularly between C0, C1 and C1, C2. And in those atlas fractures, you really want to know whether the transverse ligaments might be involved or not to assess stability. You can see some of the variations in terms of imaging regarding the transverse ligament. In older patients, there's often a large degree of osteoarthritis between the dens and the anterior arch, such that the whole motion segment may be very stiff, and this predisposes to ligamentous rupture. MRI scanning is quite sensitive for detecting spine trauma. You may see changes in the vertebral marrow signal with fractures, and it may help you in determining the timing of when those fractures occurred. This is an image of a avulsion type fracture of the basion. This is an MRI scan with an occipital condyle fracture can see the high signal intensity in the pre-cervical space, and you can also see some modest cord swelling with a spinal cord contusion. There are some features on the plain X-ray that you can also see, such as that Bayesian Dens interval being increased, or thickening of the soft tissues anterior of more than around 5 centimeters. Here you can see quite considerable pre-cervical swelling, imaged with the white asterisks, and within the canal there's an expanding hematoma, imaged with the black asterisks. This MRI scan shows a fracture dislocation. You can see considerable edema within the posterior elements. There's the obvious subluxation, and there's quite obvious cord compression and high signal within the cord. On the axial images, you can sometimes identify the little dots of the cervical roots, and as a consequence, you can sometimes see a root avulsion injury, particularly on coronal images, as shown here. Contrast enhancement of the left dorsal root is a good sign of root avulsion, but probably one of the best signs is the multifidus muscle with abnormal enhancement, as shown here. However, on clinical examination, she had developing neurological symptoms, initially starting in the hands, moving on to affect the hands and the legs. This is a spinal cord injury without obvious radiological abnormality. In fact, there is one, it's on the MRI scan. It's more common in younger children, and it's thought that as a result of the hypermobility of ligaments, a cord injury can occur, and there's no bony disruption revealed on the plain X-ray or the CT scan. So the moral of the story is, if there's a neurological abnormality, you're going to image it to find out why. I hope as a result of this session you have a better awareness of how to check X-rays, how to look for the direct and indirect signs of a fracture, and when to consider dynamic studies and when dynamic studies would be unsafe. You know now that CT scan would be your imaging of choice for significant trauma. However, if these resources are only available to you on a selective basis, you need to be selective in their use. Finally, MRI scans can be very helpful, particularly if there's any neurological involvement or you want to assess the soft tissues. Thank you very much. I hope you have enjoyed some of that.